suggests indirectly that probably she had
That's fine, yeah.
thyroiditis.
It was very thyroiditis, yeah, with some distraction of the gland and release of.
And that's the reason he recovered within a month's time and he has been.
Right, yeah.
Shall I continue with the next cases? So
Also, I have another question. In the first patient, you stopped the fludrocortisone. Why? Somebody who's primary adrenal insufficiency, usually you leave them on fludrocortisone.
Yeah, okay. Before Ava replies this, can I raise this point? So, our standard policy of giving fludrocortisone in this situation is that once you adequately the potassium is high, then you add fludrocortisone. That's what the standard teaching is there. So this person's potassium was 3.8, the first man. So why did you go on starting on fludrocortisone that time?
Yes, sir. Sir, actually, although the patient had a potassium of 3.8, but then because it was summer and the patient had postural hypotension, so considering that the patient, we couldn't set the PRA levels. So ideally, we should have sent the PRA levels to check if there is mineralocorticoid deficiency, but then we did not send, and then we had started the patient on fludrocortisone. So gradually, as we observed that the patient has improved and the sodium potassium persisted to be normal, so we tapered off and we stopped the fludrocortisone. So patient was already on hydrocortisone, sir.
Synactin, what was the synactin dose? Is it 250 microgram or 1 microgram in the second patient?
Yes, sir. So we had done a acton prolongatum. Synactin was not available here, and we did the test with the 24 units of acton prolongatum. That is the porcine sequence ACTH 139.
Just a comment on the fludrocortisone. See, normally in patients with tuberculosis, it is unlike autoimmune adrenalitis, where you find that the zona glomerulosa is first involved in autoimmune adrenalitis. That means you are hitting the mineralocorticoid first and then the glucocorticoids. Whereas in tuberculosis, it's the other way around. It starts from inside and out. So the mineralocorticoid, the glomerulosa is the last to be affected. So that is another reason maybe where you don't have to, you may not require fludrocortisone, but over a period of time, when that is also involved, maybe yes, you will require that.
Yeah.
So that's one difference between tuberculosis and versus autoimmune adrenalitis.
Another clinical point in that case was he had a BMI of 14, severely malnourished, total body electrolytes and deposits would have been very low, if I'm not mistaken, and with pain abdomen and poor eating, vomiting, his potassium can be low in that setting, even in a primary adrenal insufficiency. So we have to be very careful before commenting on the mineralocorticoid axis in somebody who has vomiting. Pseudo normokalemia can happen in somebody with vomiting. We cannot expect.
That's right. Yeah.
That was the point. And proceeding further, any comment by our panelists on recovery of adrenal functions following ATT in these kind of patients? It is highly unlikely, I suppose, because with extensive calcification she showed, I think all the adrenal would have been already closed. I don't know, but is there any data or studies from other places? Sir?
Well, for autoimmune adrenalitis, no problem. It never comes back. But for infections, I don't know. There may be some glomerulosa was spared.
Sir,
so I don't know. My experience is primarily with autoimmune.
If I can share a small experience by one of a famous Bollywood cinema personality recently. She was in fact the Miss Universe a couple of decades back. She in fact now proclaimed that she had adrenal insufficiency due to autoimmunity, and apparently she is off steroids now, and she is telling in the newspapers that she has autoimmune adrenalitis, which we all believe that it is a lifelong replacement.
Right.
Any comments, sir? Have you seen autoimmune adrenalitis recovering?
No, I
I
have a comment on that. It's very rare, but then there are reports of using rituximab as a regenerative therapy, and also they have used depo and they found that depo ACTH, I think, acton prolongatum, I think, and where they found that patient could recover. There are case reports of that, and which has been published in the JCM. So,
I have not seen anybody burnt out primary hypocortisolism reverting
I'm
back.
talking about autoimmune adrenal.
And whenever the diagnosis is there, I just tell them this is a lifelong and life-saving medicine. You need to continue this to be alive.
Yeah, I do the same. I do exactly the same.
Yeah. And regarding tuberculosis, have you had any experience of any patient recovering with ATT or something?
See, our rule of endocrinology is that 90% of the glands has to be destroyed before you develop a symptom of primary hypocortisol state. In that case, if somebody is presented with a primary hypocortisol because of bilateral tubercular adrenalitis, how much likely that they will be recovered? I will be doubtful. I am very scared to withdraw them.
Because these famous personalities are misleading them. I think there has to be some comment strongly made from our fraternity. I think you would have read that. This happened just last month. There was some discussion in our groups also on this. Anyway.
Okay, there was one issue with the ATD. I think that is a bit clear. Dr. Ganapati had something to tell about rifampicin and replacement therapy.
Yeah. So normally when you're using rifampicin, it's an enzyme inducer. So especially hydrocortisone gets metabolized more rapidly. So the dose of hydrocortisone may increase in ATT. And suppose if the patient is on an anticonvulsant, it is said that it increases the metabolism of the halogenated synthetic glucocorticoids, especially betamethasone and dexamethasone, and their dose actually increases there. So that has some effects with use of these drugs. So maybe this patient can sometimes require a higher dose also.
Yeah.
That's the comment.
And just to add to that, recently there are papers, the number of drugs which can interfere with cortisol metabolism is going on increasing. I think we have to be careful when somebody is on polypharmacy. These are all standard things which we always say, but the recent ones, there is a difference between even dexamethasone and methylprednisolone. Because this is COVID time, there was a comment on remdesivir. Actually, the metabolism of remdesivir is reduced by dexamethasone, but not by methylprednisolone. So these kind of subtle differences are there even between steroids, synthetic steroids.
Right.
Mike, sir, any comment from Dr. Crusoe, sir?
We do it simpler here. Somebody has primary adrenal insufficiency, treat them for life. Hydrocortisone plus fludrocortisone. Of course, if they take other drugs, you have to adjust the dose.
Yeah.
But basically, for replacement, we only use hydrocortisone here. And of course, we follow the plasma. We do.
Hydro?
Part of the follow-up monitoring.
With going to the next question on this.
Just a
sorry,
comment
sir,
on
please, Dr.
just a comment on the dosage of IV hydrocortisone. Nowadays, it's been found that the dose required is actually very less. See, previously we used to give 100 milligram IV followed by 100 mg 6th hourly. So that's not required. So nowadays they say just use the smaller dose. Yeah, maybe you can start at the 50 milligram bolus and 25 milligram Q 6th hourly is actually enough. And maybe even lesser than that, because they say the amount when you give 100 milligrams, the lead levels are between 40 to 100, more than what the normal person with a crisis can produce that. So the dosages are actually supposedly coming down.
Yeah, we're giving too much. You're right. If it's 10 milligrams per square meter per day, small for disorders like febrile illness, you give them twice that. And for big stresses like surgery, then you give them at most 10 times that. That's 100 milligrams at most.
Just I would like to elicit more on this. Recently, there were a couple of papers, both by Greet Vandenberg group who did that the studies on sugar. They had done ICU cortisol studies. Similarly, there is a couple of papers in the Journal of Clinical Endocrinology a few months back saying that the metabolism of cortisol is actually reduced. The excretion also is reduced. So actually, what we believe that the CRH, ACTH drive increasing the adrenal production is also there, but more importantly, it is the the excretory part which is reduced in sickness. So that may also contribute to this reduced dosing which you are all discussing, I suppose. But can that be generalized to our physicians, because already they underdose? In India, we have this problem of not giving steroids, as Ganpati sir already pointed out in his introduction.
Yes, I told in the beginning.
So my next question actually is towards that only. The challenges between India and outside India regarding the the medical alert bracelet, the sick day guidelines, in spite of giving to them, not getting followed, how much of patient education is required as well as physician education. I think I would request comments from our senior panelists on this. What challenges they face, and I as a practitioner many times I have faced this. Is children, there will be a pediatrician who will call me asking me, should I give the vaccination or not? The patient of CAH on a replacement steroids, they will get worried about giving a live vaccine, etc. So there are so many doubts in the physician's mind. So though in our endocrine forum we discuss about reducing steroids, if that is done in the practice, sometimes it is counterproductive. Kindly comment on what I mean. I would like others to share that.
We don't want to reduce steroids. We want to mimic nature. We want to give as much as they would produce. And I was at the age when we did the study with stable isotopes. That's when we were all very surprised that the production is about 10 milligrams or less, 7 to 10 milligrams of cortisol per square meter per day. We used to give something like 300 in an adult, 30 milligrams a day of hydrocortisone. Now it's at most 20, 15 to 20 in adults.
Sir, any comment from Dr. Arpandev and Dr. Ganpati sir? The challenges with sick day guidelines.
Our standard dose of Addisonian is 10-5-5. We take first thing in the morning, take 10 milligram, around midday 5 milligram, and take 5 milligram in the evening 5 p.m. Night you don't require. This is what we try to tell and start. That will make 20 milligram. And normal production of the cortisol from the gland in a healthy adult is between 15 and 35 milligram. Total is not per square meter surface area, total. So we start with the 20. Some people manage it 15, but some people require 25 or 30 milligram, depending on the situation.
We give 2/3 in the morning and 1/3 early in the evening, the afternoon.
So what time early in the evening?
8 o'clock, 2/3, and then about 6 or 7 o'clock in the evening, 1/3. And it seems that
your high zone lasts all of the day.
Say it again.
Will your high zone last for whole of the day? Suppose you get it 7 o'clock in the morning and evening 7 p.m. you are giving, that's 12 hours. Will it last for 12
hours? It lasts. It does last. Actually, many patients can do fine with one morning dose and nothing more than that. And that's because the biological half-life of the effect of cortisol is about 24 hours. So in 12 hours, you have that effect.
Okay.
It's not the same as the pharmacokinetic half-life.
Is there any
biological half-life? It's much longer.
Yeah. Is there any difference in the dosage for primary versus secondary? In the secondary adrenal insufficiency, the gland can work to some extent. For example, the patient also, she survived for 20 years without problems. She presented with a severe crisis only after 20 years. So
she's lucky she didn't have some major stress in which she would have died.
Yeah, fully.
She's lucky, just lucky.
So just as we were discussing
the same doses,
just as we were discussing mimicking physiology, what about the third hormone from the adrenal, DHEA, androgen replacement? Any comments on that, and any experience and comments on that, especially in primary? Obviously, in primary adrenal insufficiency,
people they feel better, but if you look at the stats, in women it may cause some acne, some hirsutism. So I'm not sure it's necessary, but some people say that they get more energy and they're more aggressive and
When do you
last
consider,
longer, less. In
when do
that
you
case,
consider, sir?
I give it to them.
Sir, when do you consider DHEA in your patient, Dr. Arpandev and Dr. Kanpati?
Okay, I think the answer, what I've started practicing for last few years is pretty clear. We only consider in women, number one. Number two, when I am comfortable that the compliance is correct and adequacy of glucocorticoid and fructocorticoid cortisol replacement is correct, but then also quality of life issue is not improving, I check DHEA and then give a therapy with a warning, exactly what Professor George told. The chance of acne spot or hirsutism or oily skin can be there. But I think people feel good and it is available actually now in India. Although it is
Right.
something
I'm
difficult
not
to
sure it's placebo or not placebo. Could be placebo effect. It could be placebo effect.
Agreed.
Yeah.
But I document low DHA and then I give DHA. So at least
Okay.
I am a little bit comfortable that I am not doing injustice.
Okay.
Right. Just a comment on the second case. She survived for at least 17 years later. The diagnosis was made of Sheehan's. Well, it is said that you just require approximately a serum cortisol of to saturate the glucocorticoid receptors. So that's the reason somebody having 3, 4 can go on. Surgery, maybe 5, 6 is enough for a minor surgery. So 7 is enough to saturate all the glucocorticoid receptors, and that's the reason even that small amount can sustain them for a long time. And my take on DHEA is, if they are continuing to menstruate, I'm not talking about the second case, in general I'm talking only pure adrenal insufficiency, I don't give this because they have the estrogens, they're doing okay. Maybe, yeah, post-menopausal, I would think about these things if the quality of life comes down. Otherwise, usually I'm not so much concerned.
Interestingly, even in India, the DHEA is an over-the-counter drug. Rather than DHEA is abused more than the other two in one way.
Yeah.
Sir, one more. Any comment on the recent hydrocortisone, some newer developments on the drug delivery, dual delivery, morning more, evening less, multi-delivery? Sir, any experience?
The right person, the chronocort and duocort. What is your experience?
In some people, improves the quality of life. People who feel tired in the morning. Again, it's mimicking nature. And what these drugs do is they give them a high cortisol start at about 3 or 4 a.m. in the morning. So wake up, they're already activated. Contrast to many other people with adrenal insufficiency who wake up tired, not refreshed. They have to take their dose and then 1 or 2 hours later, they feel okay and they can start their day. So in these people who are very sensitive to the presence of cortisol, these drugs are good. They improve their quality of life. For some people, it doesn't really matter. I don't know why. You know, they just wake up, take their hydrocortisone, and they do fine during the day.
One last question from my side, and later I'll give you a handover to Dr. Arpandev. Is the audience today will be very keen to listen from the panelists and the experts on this 1 microgram versus 250. And in India, we have this erratic supply of synactin, cosintropin. So we use this other intramuscular thing. So some consensus kind of some statements by our panelists will be very useful for practitioners.
May I say something?
Please,
1
sir.
microgram test is no good. Okay, you can miss a lot of adrenal insufficiency with that. We
Especially
use
in the second case, in secondary adrenal insufficiency.
Very informative. 250.
Even in secondary adrenal insufficiency, evolving.
Yes. If the adrenals are atrophic or hypotrophic, you'll pick it up with the 250. If the response is above 18 micrograms per deciliter of cortisol, between 10 and 18, you consider giving steroids. And below 10, you certainly give steroids.
So do you have any experience, or in your place, have you used this Acton prolongatum, which is the so-called replacement for cosyntropin, because in our place many times cosyntropin goes out of stock and it's a gray market and we are not able to get
it. It's the same thing here. We have a big problem with synactin. We use synactin, but every now and then, so we store it in our refrigerators to have it, because every few months deficiency.
Oh, I thought you will give me a. Okay, you are also in the same boat.
Okay.
So
just a comment
please,
on 1 microgram. See, the thing is, when you're giving a 1 microgram, you're getting blood levels of ACTH of approximately 100 picogram per ml, which is actually more than what is produced by a normal gland during stress. And suppose you are giving a 250 microgram synactin, you are producing a ACTH level of approximately 100,000, which is huge.
Yeah, it's
but then,
like a whip, a strong whip to the adrenal.
Okay.
No, I've done dose response curves with ACTH, starting from very low to very high, and I can tell you that you can miss a lot of adrenal insufficiency with those. I've published them in JCNM, several studies. You can find them. After doing a lot of studies, my conclusion was just go with a standard 250 and you'll be fine clinically. The 1 microgram is for research, not for clinical practice.
I think that's clear.
That's
no, I
real take
have one question. Suppose you have an evolving adrenal insufficiency, you may miss out if you're using a 250 micrograms. Maybe you may pick it up if you do a 1 microgram. So that's my question. That's number one. The second thing is, it said that even before the cortisol response gets decreased, the DHEA response actually comes down, and maybe the 1 microgram is useful during the evolution of an adrenal insufficiency. Your comment on that?
DHEA does not respond to ACTH. You have to wait days. Okay, it does not respond. It doesn't change. DHA does, not the steroid DHAS, the sulfate.
DHA.
Yeah. That's not, also is not a good biomarker of adrenal insufficiency. If you want a good biomarker, probably androstenedione is the best. Delta 4 androstenedione. And I've published several dose response ACTH in JCNM. If you look, you'll see what each of those low doses do to cortisol. It's very easy to make mistakes with the 1 microgram. It may stick in the syringe, whether you give it. It may stick in the tubing. You never know what you get. Believe me, it has to be done very carefully and at multiple doses.
Right, sir.
Thank you.
I wouldn't have told you otherwise, but I've spent a lot of time and money on this.
With that, I think I thank all the panelists for this session, and I hand over the microphone to Dr. Arpande for continuing with the delegates and question and answer sessions further.
Okay.
Thank you very much, sir.
Yeah, thanks, Sriram. Professor George, you have any slides to share with us?
I didn't know I had to present, otherwise I would have slides, yes. Next time.
You are the pearl of our meeting, so that's what I wanted to ask you. So all the participants, we all the time we ask, keep on question, but there are so many questions are there. So all the panelists, can you would them please unmute Ava and Ganapati, so that I can forward the questions very quickly. So we have hardly around 30 minutes time. So I try to finish within 10 minutes so that Professor George and Ganapati can take over the concluding session. So one question was there with the ATD and anti-thyroid, anti-tubercular treatment and replacement. I think that has been answered. Dr. Sushil Jindal raised a point, Ava, this is for you, that why this second person has a hot plus, because your LH is normal. I mean, what is the reason? Do you have any explanation?
No, sir. Actually,
Ava,
considering that. Yes, I can hear you, sir. So can you hear me, sir? Yes, sir. Because considering that patient. considering that patient has amenorrhea, and we can consider her as postmenopausal. So for a postmenopausal woman, the FSH is 14, sir. So which is an inappropriate response. And estradiol is also low, sir. Because of the estradiol, low estradiol, so this is a vasomotor symptom which we often see in postmenopausal. So that could be the reason of hot flushes in this patient.
Okay, that's fine. Dr. Harish Kumar asked about DHA availability. It is available, and Dr. Sriram already told that it is sometime in the gray market. And the next question to Professor George, please. Once you are starting on the replacement therapy to a diagnosed case of primary hypocortisol state, how do you assess the adequacy of replacement? Clinical, biochemical?
Most important to go clinically. So how the patient feels. If numbers, you can measure cortisol at several times after the administration of hydrocortisone in the morning to see whether it's up and whether it stays up as it should. Also, you can measure urinary free cortisol as an index that they do get enough. But I think the best titration is done with clinically, how the patient feels. And they know when they're replaced properly, they know, they feel different. They're not tired. They don't have a headache. They sleep better. They have energy. So in my opinion, the best measurement is clinical.
And how much chance is there to develop an iatrogenic Cushing? Because it is a steroid, it gives you a sense of well-being. If you give more, people feel better, more better.
Well, with hydrocortisone, it's very hard to make somebody Cushingnoid with hydrocortisone. It's a nice drug. It doesn't stay long in the plasma. If you take it once or twice a day, there is no way it can cause Cushing's. In fact, actually, if you give replacement hydrocortisone in somebody who is being suppressed because of, let's say, high doses of dexamethasone or prednisone, if you give them a morning dose of hydrocortisone, they will recover as they would have recovered if you stopped completely the glucocorticoid therapy. Okay? In other words, once a day hydrocortisone allows the axis to come back very rapidly to normal if it's suppressed.
Okay, that was the question from Dr. Raj Mohan. And a very important question now is a pregnancy with a diagnosed primary hypocortisol. Can I forward this to the Ganapati, please? Pregnancy. The question is like this: somebody diagnosed an Addison's disease. Now this lady is 27 and becomes pregnant. What will be the advice we should be giving?
She will continue to take the hydrocortisone with a comment that in the third trimester, normally they require an increase in the dose, which can vary between 2.5 to 10 milligrams because there's an increase in the free cortisol level, which can happen in the third trimester. And for labor, maybe you can give a 50 milligram IV or IM and followed postpartum for 2 days of the hydrocortisone. So, and then back to the same dose what they were taking prior to pregnancy. So the third trimester, you actually get an increase in the.
Okay, I think the two persons are raising their hand for so long time, so the hands will pain. So can you, Dr. Maithili, can you unmute yourself and talk? Dr. Maithili, can you unmute yourself and talk? Ask your question. Dr. Maithili, are you with us? Okay, we'll go back to this question now. Actum prolongatum, which asked by Dr. Shivan, which has been answered. What is the shelf life for actum prolongatum? This is for Dr. Sriram, I think. Sriram.
I have to check it up now, but we keep it for, after you open it, we keep it for 2 to 4 weeks max. Shelf life after opening, before opening, it matters. Once you start using, the only advantage we have in India in our resource constraint setting is one vial can be used for at least 4 to 6 patients.
Okay, Dr. Deepti Sharma is asking, diabetes insipidus with a pregnancy, what are the criteria of diagnosis? Dr. Deepti Sharma, you want to ask the question by unmuting yourself? I don't understand the question very well. Okay, we'll come back to that. Also, Dr. Deepti asked about the dose of hydrocortisone in pregnancy. Ganapati answered nicely. Dr. Ava, it is for you. What is the reason of pain in Addisonian crisis? What is the cause of abdominal pain?
So the cause of abdominal pain in education crisis, sir, again, like if there is an hemorrhage, there can be a very severe pain, especially in the back of the, and also because of reduced motility. Because of the reduced motility of the intestine, there can be pain, sir. And also because of hypoxia, there can be pain, sir. And it like in our case we thought that it is because of abdominal tuberculosis, and because of that the pain had occurred. So the pain again, it varies with etiology, and I think that was the reason of pain in our case.
And one question was that on Visalon. I think I am going to ask this on Indian panelists only. When do you choose Visalon, Ganapati?
Most common reason is when hydrocortisone is not available, we continue to use Visalon or prednisolone. So because availability is a problem, especially see in the metros, you don't have a problem. But when you go to the second tier or third tier cities, you don't get this hydrocortisone to use it. But otherwise, as Professor Cruz has told, the best replacement hydrocortisone
And
maybe
more relevant to this.
And then
Hello, please continue, sir.
Relevance to?
No. I wanted to comment this COVID situation. There is the lockdown and other things. The availability has drastically changed, especially with high zone. So in the last few months, we have changed not less than 10 patients to prednisolone because of the non-availability of hydrocortisone in the peripheral places.
Okay, Sriram, the continuation of that, one of the attendee who kept himself or herself as anonymous is that asking if somebody on 5 milligram of Visalon, you do a cortisol of 1.8 microgram per DL, what do you do with the report?
I don't know why they checked. It has first of all, there will be a 20 to 30% interference in the assay. And secondly, it can suppress the axis. Ideally, you should shift to hydrocortisone and shift to replacement doses and skip the night dose and check the next day morning. That will be the only way of checking. On Visalon, I would like to not interpret this and get into any problem.
The simple thing is that if you are on Visalon, don't check cortisol. It will be completely.
Many times. Correct. Yeah, many times what happens, patients are the people are checking cortisol levels on Visalon, it is low, and they continue to increase the dose, which is a wrong thing. So as you rightly told, switch them to hydrocortisone, give them replacement doses, see that the last dose is taken before 3 p.m. and then it is said not to interfere with the assays done the next day morning.
Okay. This next question is Dr. Geeta asking, I will request Professor George to take this. Now in the second patient, your free T4 was low and PSH was higher than the reference range. It was 7.2. We believe our training time we used to tell is a carries effect. So how do you interpret this report?
The ACTH levels in secondary adrenal insufficiency, when they're low, the assay is not very accurate. So below the 10 picograms per ml, you really don't know how much it is. So if it was 7, doesn't mean much. It was 7 in this patient. Cortisol is reliable. So whatever it was, 5 or 6, means that she had partial adrenal insufficiency. And that's why she was able to live so many years without major problems.
So Sir is mistaking
producing
TSH
some
for ACTH.
hydrocortisone.
I think we should
Sorry, Sriram, say again, Sriram.
No, I think Professor Crusoe is mistaking TSH for ACTH.
Oh, I'm sorry. I was thinking ACTH. Did you say TSH?
TSH, yeah. It is
Yeah.
7.
TSH.
Audio is not perfect today.
Yeah.
Okay.
TSH 7.2, Phe T4 is low. So how do you explain that?
That could be still secondary hypothyroidism.
So I believe, Dr. Geeta, the normal amount of cortisol is needed for clearance of the TSH. If your cortisol is low, TSH can be a bit higher side. And if you believe in the teleological or God-given explanation, the explanation is like that, as because the cortisol is low, the God is reducing the thyroid also so that you live longer. I mean, that's, you may allow.
Sir, another physiological explanation is cortisol usually suppresses TSH. When it goes slow, there is always a tendency for TSH to be high. In that case, one more corroborative evidence is FSH was also high. The glycoprotein hormones are going together.
Dr. Abha, Dr. Abha, can you explain your subacute thyroiditis? Is it just any coincidence or any cause and effect relation?
Sir, it could be because tuberculosis is known to cause thyroiditis, sir. So, like it could be that a patient had some tuberculosis-related thyroiditis, and we do not have any investigation or report during that time. So, it could be tuberculosis-related thyroiditis, or it could be any subacute thyroiditis at that time, because we have ruled out any autoimmunity by doing the anti-TSH receptor antibody as well as anti-TPO antibody. So it is unlikely that it is related to any autoimmune pathologies.
Okay.
While you are on the line, you're on the microphone. This is one of the questions I wanted to ask, but Dr. Binod Kumar has already asked. In the second case, at the age of 43, you started on estrogen progesterone. So what is your plan? How long you will continue?
Yes, sir. Sir, actually, in India, the mean age for menopause is ranges between 45 to 50 years of age. So, at least in these patients, we want to give it till 45, preferably till 50 years of age. But then, at least till 45 years of age, till a physiological age of menopause. And also, we have to see her BMD levels every yearly, sir. We have to because her Z score is minus 3.5. She has osteoporosis. So again, that could be related to estrogen deficiency. So we have to keep checking her BMD as well, and at least till 45 years, and preferably 50 years of age.
Yeah,
I have two questions to Abba. In the second case, why did you tell it is as pan-hypopituitarism? Because the posterior pituitary was not involved. So whenever we say pan-hypopituitarism, we mean the anterior as well as the posterior is involved. Yeah, the posterior was not involved. The second one is regarding the same thing. Somebody is not having it for a long time, say 25 years diagnosed, now she's 43. You would like to begin with estrogen first till she gets a breakthrough bleeding and then start her on progesterone?
Sir, we usually start with estrogen, progesterone, and the uterine. Although there is some menopausal changes in the uterus with that very thin endometrial lining, but in our setting, we had started a patient on oral contraceptive with estrogen, progesterone, just to increase the compliance. Definitely, an estrogen followed by a progesterone would have been a better option, sir.
Sir, one small comment and question. We were discussing the drugs and steroid dosing, and here again in OC pills we have to be careful. The dosing will go slightly higher. That is a small point which I think I'm sure they'll take care. Second is we observed, especially in these kind of long-standing hypocortisolism patients, I think Dr. Crusoe can also comment. If we give a higher dose, like for example, they come with hyponatremia or something, and the physician gives a 50 to 100 milligram hydrocort, the psychosis in the next 2-3 days, it's a big problem we face. So a general rule we are following now is Anybody with long-standing adrenal insufficiency, you start treatment, go very slow. Don't start with a higher dose, and it invariably causes some disturbance. Any comments and any guidelines or suggestions on that?
In our case, we start with replacement. We don't go slow so we start with the replacement dose. We'll see.
Have you observed this, sir? When they give this 50 and 100 milligram hydrocort for 2-3 times a day in the first 2-3 days, the second, third day itself, they go into abnormal behavior. We have had problems in the hospital. I'm sure our other panelists might have had some experience like that.
Yes. I agree with you, Sriram. Give a high dose because the sodium was say 100 milligram, and patients develop this.
And another
the rule of thumb is.
Sorry, another small observation is how much ever the sodium is low in severe adrenal insufficiency, when we treat with steroids in the first 24 to 48 hours, this usual rule that you should not increase by 8 to 10 milliequivalents per day of sodium, these things doesn't hold good. Suddenly the sodium jumps from 107 to 122 the next day, but invariably they all do very well. In contrast to SAADH or some other condition where they gave steroids. Is there any biological or any explanation for this? The body adjusts to higher doses of steroids and sodium very well in these patients, in spite of jumps. Dr. Appandev, sir, you can continue. Maybe somebody can comment.
To pick up a few more questions for Professor George. You can hear me, Professor George?
Yeah, say it again.
Two questions is there for you. One is that what level of morning cortisol you will ask for a stimulation test? What is your cutoff?
Talking about stimulation test, yes, right? Or you're talking spontaneous cortisol levels in the morning. Stimulation test, the cutoff point is 18 microgram per deciliter. In the morning, we don't pay that much attention to morning cortisol. However, if it's above 10, we almost exclude insufficiency with a morning cortisol of 10. However, if you want to be sure, you give an ACTH test.
We have actually done some study a long time back, and with a nanomole, we have found the cutoff of 200 and 400. If it is less than 200, almost always deficient. If it is more than 400, it is almost always sufficient. And in between borderline, 200 to 400 nanomole, so that we need a stimulation test.
Do you have the correspondence with micrograms per deciliter?
No, this is divided by 28, you will get a microgram per deciliter. This is nanomole per liter.
Yeah,
it is
okay.
around 7 microgram, I believe. If it is less than 7, is almost deficient. But 7 to 18, borderline, more than 18, sufficient. Something like that will come.
Right, okay. These are the numbers we usually use.
So another question for you, it's asked by Dr. Geeta. Do you do hydrocortisone day carb? And if you do, who is the good candidate to go for the day carb?
Say it again, hydrocortisone what?
Cortisol day carb. So you take multiple time of cortisol blood sample when they are on replacement therapy.
We don't normally, but if there is a question whether they're absorbing the hydrocortisone, we give them a morning dose and we take blood a few times to see whether the levels are appropriate. Now, for research studies, we do salivary cortisol many times a day, and it's very informative. Very, very informative. However, it's not good for clinical studies. You can clearly see the nice circadian rhythm just by looking at salivary cortisol.
And one is Dr. Aditya is asking about subclinical Addison's disease. What is your comment on this concept of subclinical Addison's disease?
There is subclinical Addison disease, very mild. Obviously, they don't have complete cortisol deficiency. They do produce some, so they have a milder disease. it exists, and the treatment is the same as if it was the regular disease. You give them replacement doses of hydrocortisone, and if they have primary adrenal insufficiency, you add fludrocortisone. And that we do always, both.
Okay, Dr. Sushil Jindal is asking, any comment on histoplasmosis as a cause of adrenal insufficiency, and how long should we give antifungal in this patient? Who wants to pick this up? Sriram?
No, our experience is very limited. Maybe I would have treated only 2-3 patients, and we have not seen recovery. There is a series from, I think, CMC Vellore and PGI in Chandigarh, and I am not sure of recovery in this. It is almost similar to the same answer like tuberculosis. They were given itraconazole, and itraconazole incidentally inhibits cortisol. I mean, it itself is a partial static drug. So it's a very tricky situation to evaluate. But I have not seen recovery.
Dr. Deepti Sharma, you were raising your hand for quite some time. Before your hand starts paining, can you unmute and ask your question, please?
Yeah. Can you hear me?
Yes.
Yeah, my question was not the DI. It's supposed to be the adrenal insufficiency case during pregnancy. What is the diagnostic cutoff of the cortisol level? That is one number. Number two is how much cortisol replacement you will give to maintain a good quality of life during pregnancy.
Ganapati, it's for you.
Dr. Crusoe is also raising.
Dr. George, please.
Well, I wanted to say that in pregnancy, the levels of cortisol binding globulin are very high. So if you measure cortisol levels, you have to take that into account. In other words, once normally it goes up to 20 after ACTH, in pregnancy it goes up to 40 or 50. We know that the free cortisol is going up in pregnancy, and usually in the third trimester, we give 2 to 3 times replacement dose. In other words, if it's 10 milligrams per square meter, at this time is between 20 and 30 milligrams per square meter. Starting with the middle of second trimester and then during the entire third trimester. Is a hypercortisolemic state. It's a mild Cushing's. That's the way to think about it. So they need some extra hydrocortisone. However, the measurements of cortisol in pregnancy, you have to take into account the CBG, because that brings the levels much higher, double.
Yes, thank you.
Salivary cortisol is much better than the serum. Thank you.
Yeah, but in our
salivary cortisol is better to do during pregnancy.
Available.
I didn't hear this.
Is salivary cortisol better for pregnancy?
Yeah, because it expresses free cortisol. So theoretically, it should be better. And we should normalize the free cortisol towards the salivary cortisol. But again, I would do that in a research study, not in everyday life.
What about the quality of life during the treatment or during pregnancy?
Any questions?
Quality of life during pregnancy is very difficult.
Quality of life of people with adrenal insufficiency during pregnancy.
Yes.
Is this the question?
Yes, yes. While we are giving replacement therapy, what will be the quality of life during pregnancy?
The quality of life will get worse if they don't have enough hydrocortisone. So they should be replaced properly.
Yeah, I think
they may feel they have adrenal insufficiency and they don't increase their dose in the third trimester, they may not feel well.
Okay.
So they have some form of cortisol deficiency.
Okay, I have a very interesting question here from Dr. Nisha from Cochin. Now, I would like to read this. Mother and a daughter both diagnosed with hypocortisolism at 26 years and 16 years respectively. Accumulated cortisol all less than 1, ACTH multiple times single digit. There's normal PRA, normal pituitary gland, genetics not done. So diagnosed as an isolated ACTH deficiency. Now, Dr. Nisha is asking whether there is an entity called familial isolated ACTH deficiency. Any of
Yes,
the
there is.
pick up. Yes, it is.
Yes, there is. It's a familial. It can be a familial disorder, and there are multiple reasons for that. One, the most common probably is isolated ACTH resistance. In other words, the adrenals don't do ACTH properly. So it's isolated cortisol deficiency. But there is also isolated pituitary ACTH deficiency. And presumably it's an autoimmune disorder, but an autoimmune disorder can occur in a familial fashion. Because, as you know, there is increased predisposition when you have autoimmune predisposition for disorders.
Is it only possible that only corticotropes are being affected by the autoimmune process?
Yes, exactly. It's possible. Yeah.
Well,
We used to have
I have seen only
very, very rare. So I've never seen it here in Greece, but at the NIH we had a program of them throughout the country. Yes, I've seen it, and it's isolated, and it may be autoimmune.
That's nice. Dr. Nisha, I have seen only one in my life, and isolated one single case. I have no idea about this. And a very interesting question is there. I think I am going to ask this to Dr. Sriram about your guidance for interpretation of adrenal insufficiency in critical care setting. Cutoff value. We are very clear cutoff value you want.
That's a controversial thing. If it's in a non-adrenal insufficiency patient, it's very easy to answer that you replace it as stiffly as possible. And we have discussed today that you keep it low, maybe 50 milligram IV TDS, or that would be fine. But there are some recent reports coming on IV infusion continuously is probably better than boluses of hydrocortisone. This is apart. In a normal patient who is becoming, otherwise a normal person who became sick and now he is critically ill, the critical care guidelines are very different. The endocrine, their cutoffs, they use the word called relative adrenal insufficiency, or CIRCI, which is corticosteroid insufficiency in sick patients, something like that. So there they use this stimulation test as the cutoff, and when there is less than 9 microgram per DL response, delta response, they take it as relative, and there they give not only 50 milligram IV 6-hourly and also fludrocortisone, and some studies don't use fludrocortisone. So it's a very heterogeneous way the studies have done. The general recommendation, consensus among them, if I have spoken to quite a few senior intensivists in quite a few parts of India as well as in Chennai, there are some senior people. The overall consensus is if anybody who is requiring high doses of inotropes and fluid boluses and not responding, if they are still in hypotension or they are in septic shock, you give steroids. See for 3 to 4 days. If there is a good response, they continue it. If there is no response, they take it off. This is irrespective of the cortisol level. That's what they follow in our ICU, in some very good ICU academic centers. So this is a general recommendation I can suggest. If you go into the studies, it's very, there are so many reviews on this. And I think recently in ESI, our endocrine society also conducted one critical care seminar, webinar series. I'm sure you can quote studies for and against what I'm saying. But the general consensus is somebody not responding, he's in shock, not responding to requiring high dose of inotropes, give the benefit of doubt, treat it, but have a finite outcome, finite period of time, 4 days. What they have shown is it does not improve mortality, but they come out of shock. This is what is the overall, what you call a systematic review.
Okay, thanks. Professor George, you have any experience of subcutaneous hydrocortisone infusion pump?
It should work exactly the same way as if you take it orally. Yeah, it's no problem. It's a hormone that's nicely absorbed.
Sir,
and you can give it perfectly through subQ.
A small
no
question.
problem.
With thyroid, we have this problem of atrophic gastritis in autoimmune conditions causing interference in the absorption. Have you encountered with hydrocortisone?
We never had this problem, not that I know. But
Because in
believe me,
thyroxine
hydrocortisone can be given in any way.
Thyroxine
very
literature,
nice.
there are a lot of studies on atrophic gastritis interfering with absorption.
I know.
Well, Dr. Ava, you are fresh from all of your academic studies now. You need to answer this question asked by two people. What is the protocol of cortisol replacement after transphenol surgery for pituitary adenoma? And if you decide to do a dynamic test, how will you go forward?
Yes, sir. So, after pituitary surgery, like before pituitary surgery, the patient has to be started on hydrocortisone itself for any pituitary adenoma, and because there can be there can be adrenal insufficiency or hypocortisolism just after surgery. So we give a start dose of 100 milligram of hydrocortisone just before the surgery. Then followed by that, we continue giving a 100 milligram 6 hourly. But then now there are guidelines and studies that say that do not give more than 200 milligram of per day of hydrocortisone. Even 50 milligram 6 hourly is sufficient. However, even if we are giving old patients, like we are giving 100 milligram 6 hourly, then we gradually taper off, and over like next 2-3 days we taper off, and then we assess the cortisol level on the day 5 in our patients. Then if the cortisol level is low, then and we do an acetate stimulation test, and if it is low, then definitely we continue the patient on oral hydrocortisone replacement therapy.
Okay, thank you very much. I think the first person who learned maximum for today's all this actually is myself, that at least another 25 questions are there. Suddenly I am realizing it is 8:30. Thanks very much for all panelists. That's all from me. I will now hand over to Dr. Ganapathy for the rest of the proceedings. Sorry, I've done late. I didn't realize the time is gone.
Okay. Thank you, Dr. Arpan. First, I would like to thank Dr. Abha for presenting two very interesting cases, which is specific for India. You spoke about the Sheehan's, and also you spoke about tuberculosis as primary adrenal insufficiency. This is more common in India than the Western world, where you find that autoimmune adrenal is the most common condition. So thank you very much for choosing this condition. So and then I thank all the panelists, Professor George Cruzes. We are extremely grateful for you having come here and shared your opinion. We would like to have you in the furthermore series to come. We'll be in touch with you, sir. Thank you very much.
It's a pleasure. Thank you very much.
I would like to thank Dr. Arpan and Dr. Sriram for moderating and chairing this session. Great work done by both of them. Then we learned a lot actually about primary and secondary adrenal insufficiency, especially in the isolated instances. I never come across. Thanks for that. So overall, it's been a good learning session. I think we'll have in the next series furthermore to learn. I think I want all of you to come and join to that. I hand over now to Dr. Gurunath.
Yes, sir. At last, sir, just a vote of thanks, sir. It has been a very informative and interactive session, sir, on the topic adrenal insufficiency in the adults. My gratitude to Dr. Sanjay Kalra for helping and guiding us for organizing this webinar series under the banner of EPIC. I would like to thank Professor Ganapathy Batwal for chairing the session so specially, sir. My special gratitude to Professor George Cruzes for being the international chairperson for very informative and panel discussion. I would like to extend my thanks and sincere gratitude to Dr. Sriram Madhavan for being the national expert. My special thanks to Dr. Arpan Dev Bhattacharya ji for making the session more likely and moderating the question and answer session as chairperson. Most importantly, I would like to thank Dr. Abhamoni, Baro, Agarwal for such an educative and enlightening case presentation on the topic. I would like to thank all the esteemed delegates for sparing time from their busy schedule and attending this webinar. We are looking forward for your participation in the entire series of webinar sessions, sir. A big thanks to all esteemed doctors from Samarth Life Sciences. We are the makers of Hyzone and Fuloricort, that is hydrocortisone and fluorocortisone, sir. Thank you very much, sir. Thank you.
Thank you.
Thank you.